we'll start off by talking about dasatinib low dose and versus standard of care. These are four things which came up to my interest that I thought a community physician should know and at least be aware of while they are practicing. There was no major big splash that occurred at ASH 2021. But again, these are four that I think would be useful to know as we all see patients. So let's start off with dasatinib low dose versus standard of care. All right, so the question is low dose dasatinib just as efficacious or maybe more as compared to standard dose dasatinib for patients with chronic myeloid leukemia in chronic phase in the frontline setting? So first line, which one is better, low dose or the standard? So the study that was shown, and as we'll see in the next slide, was a propensity scored matched analysis. About 233 patients were collected who were all newly diagnosed with chronic phase CML, and they were broken down into two groups. Remember, this is not a clinical trial, this is a retrospective study. So the standard dose arm had about 150 patients who got the standard dose as the one which is used from the NS10D trial. It's on the label. So the standard dose being 100 milligrams per day, while the low dose dasatinib arm had 50 milligrams per day, and there were about 83 patients. Now, those who did receive low dose dasatinib, they had the option of going up. The physicians had the option of increasing the dose to 100 milligrams of dasatinib if there was suboptimal response by the ELN criteria. The endpoints which were assessed in this study were the usual endpoints for CML, like failure-free survival, event-free survival, also transformation-free survival, transformation being to accelerated phase or blast phase, and also the overall survival. But I think if you had to ask me which one of these main points was the key item to look at, I would actually argue it was the safety. Anyone who has used dasatinib knows that dasatinib causes pleural effusions, also pulmonary hypertension, and that can be an issue. When we use standard dose dasatinib at 100 milligrams per day, the pleural effusion rate is about 25%, and these can occur even years later sometimes. So again, coming back to the study, what was seen is something that we'll see in the following slide. So let's move on. All right, so I would suggest not looking at the middle column, actually rather to look on the right side, which is that after propensity score match analysis, there were 77 patients identified from the low dose group, which is 50 milligrams daily, and a same number, 77 patients from the standard dose of 100 milligrams daily. In terms of median age, spleen size, white blood cell count, hemoglobin, platelets, basophils, blasts in the bone marrow, well, all these, as well as the so-called risk group, like low risk group, intermediate, and high, these were all matched, as they should be in propensity matched score analysis. So moving on to the next slide, which is that of efficacy. So let's look at what the efficacy was seen. In the top, what we are seeing is the 4-year failure-free survival, 4-year EFS, TFS, and OS. As you can see that the 4-year overall survival, as well as transformation-free survival and event-free survival, was no different between the low dose and the standard dose groups. The failure-free survival was actually in favor of low dose as compared to standard dose dasatinib. You might ask, what is so different in failure-free survival compared to EFS? They sound very similar. Well, actually, failure-free survival also includes the endpoint of discontinuing a drug for any reason. So if a patient stops or a physician stops, whatever the reason be, that could be toxicity or we don't like it, there's no efficacy, that is counted in FFS, but not in EFS. Now, what about the cumulative incidence of response? So the first one, that is the 36-month or 3-year complete cytogenetic response, that was in favor of low-dose dasatinib. the major molecular response, or MMR, which means a BCR-ABL of less than 0.1%, it was also in favor of low-dose dasatinib, although it didn't meet the statistical significance, while very deep remissions of less than 0.01% or less than 0.0032%, called as MR 4.5, they were also once again in favor of low-dose dasatinib, but also importantly, met the statistical significance cutoff of 0.05. All right, let's move on to the next slide. Here we are looking at the adverse events. Remember I said, I think safety is just as important when we are comparing two different doses. So what we are seeing at the top is the hematologic site of adverse events, and they were really not statistically significantly different between the two groups. But the key point is at the very bottom, which is that of pleural effusions. Pleural effusions of any grade occurred in 5% of patients with low-dose dasatinib, as opposed to 21%, which is in line with the 25% that I just told you about. So a big difference was noted over there. Moving on to the next slide. Here we are seeing that the patients who were on the low-dose dasatinib arm, the vast majority of them stayed on the 50 milligram dose, while only about half of the patients who started off at a dose of 100 milligrams on the standard arm were still at 100 milligrams. In other words, the majority had to cut down their dose to lower doses like 80, 70, 60, 50, and whatnot. So in terms of dose escalation, barely 2 patients out of 77 in the standard in the low dose dasatinib group had to escalate their dose. So overall, what this shows is that the low dose dasatinib arm group patients were patients who did really well. The dose interruptions were very low, as you can see, 7% as compared to the standard dose, meaning once they were on it, they stayed on it, and for the vast majority of the time, nothing needed to be interrupted or changed. Moving on to the next slide. This is the key point that we also touched upon before, that the low dose dasatinib was just as efficacious as standard dose dasatinib in patients with newly diagnosed CML in chronic phase, and that the safety data actually suggests that low dose dasatinib results in less intolerance. All right, next slide. Fantastic. So one could actually consider using low dose dasatinib in their practice for patients with CML in chronic phase who are newly diagnosed. I can tell you that personally, I have been doing that myself for about 2 to 3 years. And the beauty about it is you can keep the patients on the same dose, not have to hold the dose, modify the dose, recheck the counts, transfuse. A rather low dose dasatinib just stays in continuously without causing many fluctuations. In fact, why were the outcomes better with low dose dasatinib as compared to higher dose dasatinib? We think that the reason was that with low dose dasatinib, the interruptions were so less that you could keep the patients on the same dose for a longer period of time, which then subsequently resulted in better outcomes. All right, moving on to the next slide. So after that one CML topic, let's go to the next one, which is that of ASSEMBLE trial, which was presented, the 48-week updated analysis was presented at this past ASH. So the question was, does the use of a STAMP inhibitor, asciminib, versus bosutinib provide benefit for patients with CML in chronic phase after prior TKIs? What is STAMP? Well, let's think about imatinib, dasatinib, nilotinib, bosutinib, the standard first and second generation TKIs. What those are that they are ATP inhibitors. So the BCR-ABL ATP binding site is where those TKIs go in and block the activity. While STAMP, which stands for specifically targeting ABL myristoyl pocket, it is outside of the ATP binding site. So it's this drug, asciminib, does not work in the same manner as the other TKIs that we are so used to using. So again, the question was asciminib versus bosutinib, which one is better for chronic phase CML patients who have seen prior TKIs? So in the next slide, what we are seeing is that asciminib was actually granted accelerated approval on October 29, 2021, with the brand name of Scemblix from Novartis for patients with Philadelphia chromosome positive CML in chronic phase who have been previously treated with 2 or more TKIs. But the FDA also approved it, a regular approval, I should say, for patients with Philly positive CML in chronic phase with the T315I mutation, the gatekeeper mutation, for which right now, prior to asciminib's approval, we had only one specific drug, that being ponatinib. So what's the data for the accelerated approval? Moving on to the next slide. In the assembled clinical trial, which was presented, it was a randomized phase 3 clinical trials where patients had seen at least 2, if not more, prior TKIs. They were still in chronic phase. They could have failed or be intolerant to the most recent TKI that they used. And patients had to have no T315I mutation or the V299L mutation. Why were those two excluded? Well, because if you were to somehow get randomized onto bosutinib, bosutinib doesn't work on those. So you had to randomize it to exclude those patients. Well, the randomization occurred in a 2-to-1 fashion. Those who were randomized to asciminib got the dose of 40 milligrams twice daily, which by the way is the FDA approved dose now, or bosutinib at the standard dose of 500 milligrams once daily. The primary endpoint was major molecular response at week 24 or 6 months. And as our attendees would know, that in CML, what we know for sure is that achieving MMR, meaning a BCR-ABL1 of less than 0.1% and consistently having that, has a survival advantage as compared to not achieving it. What we try to do is that we also try to achieve complete molecular response. And while that's great, there is no survival advantage of achieving complete molecular response as opposed to achieving just MMR. And hence the fact that this trial, once again, like many other trials, was shooting for at least MMR at week 24. So in the next slide, what we are seeing is the patient disposition to the 2 groups of asciminib and bosutinib. Now, in terms of treatment ongoing, what you are seeing is that at 48 weeks and beyond the data cutoff, which was about a year ago, at that time of data cutoff, more patients with asciminib were still on treatment as compared to bosutinib. And the reason for discontinuation was lack of efficacy in about 35% of patients with bosutinib, while that number was much less for asciminib. Moving on to the next slide, which is where the money is. Let's look at what the primary endpoint outcomes were. So MMR, the less than 0.1% that we talked about at week 48, that was achieved at week 48 in 29.3% of patients who were randomized to the asciminib arm as compared to just 13.2% in the bosutinib arm. The overall outcome of less than 1%, so not MMR, but MR2, or that is less than 1%, was also much higher in asciminib arm as compared to bosutinib arm. The cumulative incidence of MMR, meaning you achieved, but maybe you lost it, but you still get counted, that was higher also, once again, as expected in the asciminib arm at 33% as compared to just around 18-19% in the bosutinib arm. All right, in the next slide, we are seeing some more efficacy results. And here what we are seeing is that even the deeper remissions like MR4, which means less than 0.01%, or MR 4.5, those numbers were also higher in the asciminib arm as compared to bosutinib. The median time to treatment failure was actually not reached in asciminib, while it was around 6 months for those who were randomized to bosutinib. All right, moving on to the next slide. And here, I think this is important to see, and it really contrasts the two drugs that the patients received on this trial. So if you look at the bottom half, it talks about the adverse events that occurred in 20% or more of the patients. Those who were randomized to asciminib had more thrombocytopenia and more neutropenia, so more hematologic toxicity as compared to bosutinib. The numbers were not dramatically different, but nevertheless, it occurred more in asciminib arm compared to bosutinib. While in the bottom half, what we are seeing are the classic adverse events that we see with bosutinib and have been known for quite some time. So those being the GI adverse events like nausea, vomiting, diarrhea, as well as the increased LFTs and rash. So in particular, if you were to look at, for example, diarrhea, any grade diarrhea occurred in 71% of patients with bosutinib, while it was only 11 or 12% in asciminib. So a very different safety profile for the two drugs. All right, next slide. Great, thank you. So here what we are seeing, and to simplify and summarize this, what we are seeing in this slide is that for the vast majority of patients who got asciminib and had thrombocytopenia or neutropenia, those occurred in the first 6 months. To have new thrombocytopenia or neutropenia after the first 6 months was extremely rare. So once again, it's good to keep this in mind as we practice that, hey, if we are going to deal with it, it's going to happen much early rather than later. All right, next slide. And the arterial occlusion events were slightly higher in patients with asciminib as compared to bosutinib. However, two things are worth noting: that although there is a 4.5% versus 1.3% difference, the difference being small, but nevertheless being there, two things to consider. One is that the patients who were on the bosutinib arm, most of them did not stay on the bosutinib arm for a long time, meaning we didn't have enough time to acquire the arterial occlusion events. But number two, that the patients who had these arterial occlusion events on the asciminib arm, they were on, for example, nilotinib, ponatinib, two very well-known cardiovascular toxicity having drugs prior to them going on asciminib. All right, next slide. So overall, I think that the safety results were consistent with primary analysis. There were no real new signals that came out. And to conclude this part, I think it showed that the efficacy endpoint was achieved in more number of patients who got asciminib as compared to bosutinib, using the MMR cutoff of less than 0.1% BCR-ABL in patients with CML chronic phase who had seen 2 or more TKIs. All right, let's go to the next slide. We talked about this. And so moving on to the third topic, which I think is good to know, which is that of CPX-351 versus hypomethylating agent and venetoclax. So let's go to the next slide. I don't know how many of our community oncology attendees over here use Vyxeos. I don't even fully know how many of you take care of AML patients, but I won't dwell too much onto this given that reason, but I will say that that Vyxeos is FDA approved for patients who have therapy-related AML or secondary AML or AML with myelodysplasia-related changes, while HMA-VEN, that means azacitidine or decitabine plus venetoclax, is approved for patients who are above the age of 75 or those younger patients who cannot get intensive chemotherapy. Largely speaking, there's an overlapping patient population. So the natural question is, which one is better to use when you have such a patient in your clinic? So next slide, what it shows is that a group of 4 institutions collected their data from Moffitt, Cornell, MSKCC, and Northwestern. About 448 patients were there. It's a retrospective study. Patients were divided into 2 groups, the one being CPX351, that's Vixios, and HMA plus 1. The primary outcomes were response rate, overall survival, and relapse-free survival. Moving on to the next slide. First, on the left side, you have the overall population. So anyone who got either of these 2 drugs were included in that. But I think if you ask me, that the key question is not about overall population. Rather, the key question is about the 60 to 75-year age group and to see what happens over there. So here, the median age was still statistically significantly different in favor of CPX351, while some of these mutation profiles were also slightly different between the 2 groups. And I just wanted to point out more P53 mutations in the HMA plus venetoclax group, more RUNX1, more ASXL1. So again, favoring CPX351 group more so than HMA1. All right, next slide. The CR/CRI rates for the overall population was around 56%, so not statistically significantly different. In terms of P53 mutant patients, there was a statistically significantly higher CR/CRI rate for those who received HMA plus venetoclax. Moving on to the next slide. For the overall population, the median survival was statistically significantly in favor of CPX351. But like I said, I think the key question is not the overall population. The key question is 60 to 75-year age group. And let's move on to the next slide. Here, what's shown is that in the 60 to 75-year age group, the median survival, while different and showing a higher number for 17.1 versus 10.3 months, was actually not statistically significantly different. And maybe the big reason why the difference was seen was actually because of the higher transplant numbers in the CPX351 group. Of course, all the confounding factors go into play over here, as we know, because probably the reason why many patients received CPX351 was because they were fit enough to get it, and hence the same population then ends up also getting transplants. All right, so moving on to the next slide. Here's the conclusion part, which is that there was no significant difference in terms of response rates between the 2 arms, CPX351 and HMA-VEN, in the overall population or the 60 to 75-year group. The OS was greater in the Vixios arm compared to the HMA-VEN arm when you looked at the overall population, but not so much when you looked at just the key age group of 60 to 75 years. And the subgroup analysis actually showed a higher OS with CPX351 Vixios for those patients who had TP53 mutations. All right, next slide. And next slide. Now, this is the 4th topic, and I just want to glance over it and just make you aware about it, which is that of IPSS molecular risk stratification. Let's move on. We don't need to dwell too deep into this for now, but the question was, will the IPSS molecular or molecular IPSS improve the risk stratification and lead to better treatment decisions for patients with MDS? So in routine practice, I'm sure when you see a patient right now, I'm sure you are doing either IPSS or IPSS-R, the revised IPSS, or the WHO IPSS scoring systems. So, but none of those include molecular scores, the things that we get from next generation sequencing panel, which says P53 mutations and whatnot. We don't incorporate those. So the question was, does incorporating molecular information improve the risk stratification? So next slide. Uh, in this massive cohort of almost 3,000 patients from the International Working Group, which formed the discovery cohort, and then in a validation cohort from Japan, which had 750 patients, about 156 driver genes were profiled, and 48 genes were mutated in 1 or more percent of patients. The mutations were subdivided into favorable and adverse risk. The adverse ones were P53, MLL, and FLT3, while on the favorable side, we had the usual suspects like SF3B1, BCOR, RUNX1, NRAS, and STAC2, as well as SRSF2. So next slide. What we learned from this abstract was that in the eventual IPSS-M, there were about 17 genetic variables identified from 16 main genes and 1 genetic variable from 15 residual genes. And when they risk stratified and achieved a new scoring system, there were 6 risk groups that were established, as we'll see in the next slide. All right, so just wanted to show this picture, the one on the left, which shows that curve. Important point to note is that this is more of a continuous variable score, right? So as opposed to saying a score of 7.1 or 7.5 and 8 or 8.5, this is more of a continuous risk stratification. And overall, the patients were subdivided into 6 risk groups. On to the next slide. We talked about the left side of the story, which is that right now we use WPSS or IPSS, or what I use the most, which is IPSS-R. But the IPSS-M, the one that was just shown, has a potential for making things more, or rather, making the risk stratification and treatment decisions better. There is a web calculator that's available, and even if you happen to not have some information, for example, you did a bone marrow, cytogenetics were obtained, but you couldn't get the results, it was unsuccessful, this calculation still takes that into account. So I just wanted to show this and keep you aware of it. I would say use at least 1 risk stratification, like IPSS-R, but also start looking into IPSS-M, especially when you have difficult patients or patients who don't make complete sense. They show up as low risk or intermediate risk on IPSS-R, but they're behaving more severely. I think that's where one could use right now. I think that's it from my end.
Thank you, Dr. Bashani. A lot of good stuff there. Really appreciate it. Again, Dr. Kalmati, Dr. Schaefer, you were answering a number of the Q&A. Are there any Q&As that you'd like to go ahead and introduce to Dr. Bashani?
Sure, Joel, I think there are 2, and one of them is kind of a general question. So Dr. Bashani, if you have a brand new patient with CML, what is your algorithm that you use? And do you start at, or are you going to start at 50? Do you start at 70 milligrams of dasatinib? And what's your second line agent? What's your third line agent? And secondly, in people that have GI toxicities such as pancreatitis, we know that nilotinib can do it, but they all can do it. What do you use to determine which TKIs you use?
Yeah, great question. So let me first start by answering the first one, which is that of what's my frontline TKI of choice. Well, the first thing to do when you get a new CML patient is to do a bone marrow biopsy, figure out the blast percentage, and do the appropriate risk stratification. If they happen to have low risk disease, now that could be by UTAS or SoCal score. Most commonly, it's the SoCal score that we use. There's a calculator available online for that too. The go-to treatment there is still imatinib. If you look at the NCCN guidelines, or for that matter, any other guideline as well, imatinib is still recommended as the treatment of choice in low-risk groups. For intermediate and high risk, we generally perform a second generation TKI. And my choice there, my personal choice is dasatinib at 50 milligrams, the data for which I actually showed. My personal experience, and I don't have the data to actually tell you about, but my personal experience in maybe 20 plus patients like that is actually very much in line with the data that was shown. Rarely have I ever seen a pleural effusion. The treatment goes very smooth. You don't have to start and stop and all that. Now, what would be the second line and beyond treatment choices? Partly depends on why you need to change. If you need to change for efficacy, and by that I mean lack of efficacy, the treatment of choice would be another second generation TKI, if you didn't already use one, or something like ponatinib there, if you happen to have a mutation. In general, I will say, and this is a very in general comment, that if you are moving from one TKI to another TKI because of intolerance, like hematologic toxicity, you started someone on TKI, but they're having severe thrombocytopenia, which happens every now and then. Switching to another TKI will probably cause the same intolerance that you saw before. Reasonable to change, but keep that in mind that you're more likely than not probably going to discover the same thing. I would, in that case, make the second TKI choice based on an individual patient's comorbidities. For example, hyperlipidemia, if they have GI issues from before, why pick something that may cause the same thing again? If they have COPD, heart issues, why pick nilotinib or dasatinib? Why not pick something else, like bosutinib there? We now also have asciminib as an option that we talked about. And I think there was one more question. Yes, pancreatitis. Might I answer that question with one of our questions in the case studies? We are actually touching upon this.
Sounds great.
Yeah.
Thanks, Dr. Vachani. Dr. Kalmadi, you want to close us out? There's actually one more question. It's in the chat room.
Absolutely. So the question is that of magrolimab plus venetoclax rather than CPX-351. Firstly, for those who don't know, magrolimab is an anti-CD47 antibody. It is not FDA approved for use in patients right now. It is being investigated in clinical trials. It looks very promising, but it's not available to use. I'm personally putting my patients like that on the magrolimab plus azacitidine plus venetoclax trial if they have AML, and if they have MDS, then on magrolimab plus azacitidine arm. But we'll just have to wait and see. I will tell you right now that as of maybe about 2 weeks ago, the FDA put a partial hold on the azacitidine plus magrolimab studies, be that MDS or AML, because there was a signal seen with more anemia on the magrolimab arm. Some of you may know that the use of magrolimab can actually wipe out the older RBCs which express CD47. The new RBCs don't express it. So this is something that we'll just have to wait and watch. Although my feeling is that we will be using magrolimab there, but we just have to wait for maybe a year or two more.
Great. And just to close it out, if you can look in the Q&A, there's if you can handle that one really quick before Dr. Kalmadi goes up.
Sure.
The question is, when would you use asciminib in your schema? Would you use it third line, fourth line?
Oh, got it. Okay, so I somehow can't see that. I would use it in the third line setting right now. And again, we have a question related to when to possibly use it even before third line in the case study. But as things stand, and from the data that was shown, I would use it in the third line setting right now.
Great, thank you.